Hi,
Hey,
everybody. This is Susan Clinton, your host for Tough to Treat. This is episode number 180, and we're excited because we've been asking people for the last couple of months if you have a Tough to Treat client to come on and talk with us about it and do some brainstorming. In this episode, we have Megan Barclay, a physical therapist from New York City, joining us today with a client that I think everybody will find fascinating and interesting. And we look forward to hearing your feedback. Thank you so much and enjoy the episode. Hi, everybody. Welcome to Tough to Treat. This is podcast number 180. I'm Susan Clinton, one of your hosts for the podcast, and I'm here with Erica. Hi, Erica. How are you today?
I am wonderful, Susan, and we have a third person on our episode today,
We
and
do.
we do. Her name is Megan Barclay, and she is a wonderful therapist here in New York City. And we've been making the call to listeners if you guys want to come on and run a tough patient scenario by us. Feel free to email us toughtotreatpt@gmail.com, and we'll have you on just like Megan. And I know Megan wants to get our opinions on a couple of patients. So Megan, just introduce yourself briefly, and then just dive right in.
Okay. Hi, guys. My
Hi.
name is Megan Barclay. I'm a physical therapist. I specialize in orthopedic sports physical therapy in New York City and in Westchester. I've been a PT for 23 years now. Undergraduate, I was a psych major. I studied human factor psychology and sensation perception. And I only mention that because I find that info really interesting in terms of this case that I'd like to discuss with you. And I'm so excited to have this opportunity to speak to both of you and get some insight.
Awesome. Well, we're happy to have you. So, do you want to just give us a bit of a background, and so the listeners can get an idea of what type of patient this is?
Okay, sure. I have a patient that I'm treating currently. Is a 48-year-old active male, and he came to me with neck pain, which began over a year ago. Well, actually, what happened was he was on vacation, April 2022, and he thought he had a sunburn on his head. He's a little balding on top, and it felt like a sunburn. And so then the next day he flew home and the pain increased. He got sharp little needle points, it got itchy, and then blisters started developing. So he went to urgent care and he was diagnosed with shingles. So they prescribed Valtrex for a week, and then he followed up, and then they did another week of Valtrex, and then that, the blisters and everything subsided. However, he was advised to go get checked out by ENT. His hearing was fine. Went to the ophthalmologist. Everything was fine with his vision. Luckily, that can be pretty scary. And they gave him Lidoderm lotion to help with the scalp. And in addition, he actually switched neurologists. He started with this first neurologist who had prescribed gabapentin, 600 milligrams twice a day. And then he had switched over to a neurologist in New York City. He was still dealing with the pain from the shingles. And so this other neurologist started to lower the dose of the gabapentin down to 200 milligrams twice a day, in the morning and night, and then was slowly trying to get it down. They had also tried OxyContin a little bit. That didn't seem to help. So the presentation, when he came to me, was he's had this constant, for the last 4 months, pain that's been the same and nothing has really changed. It was like a 2 to 3 out of 10 dull pain up the left side of his neck into his scalp. He also was complaining about left-sided neck pain that he would experience while playing tennis. So he's an active guy, played hockey, played tennis, and the neck pain that he would have, they would be like zingers, like sharp pain shooting up the back of his head on the left side. And he had that like 3 times over the last maybe 9 months. So I was, interested to hear the story to try to figure out, is this a cervicogenic? Is this a trigeminal issue? Or is this like a post-herpetic neuralgia? So should I continue?
Yes, please.
Yeah.
Okay. So I went on to, let me just make sure I'm just reading my notes, make sure I have everything here. Oh, the things that I was asking, like what increases it? And the only thing that he could say was, which I found interesting, which I really don't know much about, is whenever he would eat beer or drink beer or eat pizza, the next morning the pain would go up to like a 4 out of 10. So, or lack of sleep and stress, whether or not gluten had an impact. I really, I don't have much training in nutrition, so that was something that I needed to look into. And all I could really find was, people with celiac disease have a 2 or 2.5 times increased rate of developing like a neuropathy in a JAMA article, but he hasn't been diagnosed with celiac. So I thought that was pretty interesting, because I always try to ask, like, what increases it? What makes this worse? So there are these 2 different symptoms going on. One is I did, range of motion testing, and left rotation increases the pain like in the C3, C4 area, but then there's just that general dull pain that goes up his head into the scalp. So he, go ahead.
No, Megan, just when you say when he turns his C-spine rotation left, that just increases his left side of his neck pain, but doesn't make his scalp issue any change, correct?
Correct.
Okay.
So he had this neurologist in New York City ordered a cervical spine MRI, and it just showed basically left multi-level degenerative changes, which I consider pretty normal for anyone over 30. Left greater than right foraminal stenosis, that was like moderate. C3, C4 disc osteophyte complex. And then C2, C3 minimal facet arthrosis, but nothing crazy. The neurologist in New York City, talked a little bit about an occipital nerve block. He really didn't want to try that yet, but the goal is to taper the gabapentin. I asked about history of motor vehicle accidents, whiplash, nothing. He was using a mouth guard before the shingles incident. I have something in my notes here about a wisdom tooth on the right, but I didn't write anything else about that. So I did look at his posture. I sent you guys some pictures so that you could see too.
Yeah.
Before we head into the posture, I have a couple of questions.
Yeah, you go ahead first, Susan, then I'll follow up.
So this guy played hockey.
Yeah.
Ice hockey, Megan, or field hockey, or ice hockey?
Yeah, ice hockey. And don't even go there. My son plays ice hockey. I'm like crazy about concussions. And, he says there's been no history.
Yeah, he's had history. He just isn't putting it together with that because it's
totally
in hockey. So I just wanted to bring that up for the listeners. It's like, we know this guy has had some history of something because he played hockey.
Yeah,
for sure, 100%. And these subconcussions, that people didn't really even pay attention 2 years ago are more important than anyone ever realized, and it's just getting attention now.
Yeah,
exactly. So the other one I wanted to kind of just touch on real quick is the lack of sleep and stress makes it worse. And also if he has beer and pizza. And yes, here's the thing. He may not be celiac. He may be a silent celiac that nobody ever knew. But when you have like shingles, that resets the immune system. And because the shingles virus hangs out in the body well beyond the expression of the blisters and that the temperature change and all of that. The interesting thing about this is that so he could be extremely sensitive to gluten now, because the immune system in the gut has been reset and changed, and if he's been running with persistent pain since then and on GABA, there's all bets are off on what he can tolerate right now. It could be gluten, and it could be dairy as well. And so those might be some things in his just lifestyle things for him to just maybe kind of stay away from those everywhere and see how that affects anything.
And it's a consistent finding on his behalf, reliable, and he does know this about his body.
Yeah, it may help him in time, and just really kind of just focusing on anti-inflammatory type foods as much as possible, just for the gut immune healing that goes along with this post-shingles kind of stuff that's happening here. So those were
and I think that also, when he started taking the gabapentin, he said he didn't drink any alcohol for a few months. He did say he didn't think caffeine triggered anything. He does drink caffeine. He has a pretty demanding job. And so I thought that was interesting too. And he's not describing it actually as like a headache either. So
Megan, what does he do for a living?
He's in the financial industry.
Okay. Yeah. So, because shingles and COVID and all these viruses, they're neurogenic, right? And so they're going to hit you at your most vulnerable area, like your after effects of supposedly when the virus leaves your body. Even though he didn't probably say he had an overt concussion or any head issues, as Susan said, ice hockey, you're getting them. You're getting them, whether you know it or not. And because of that, and I think because of the virus, it does lower your guard and it increases your susceptibility to things that in the past may not have bothered you, but they're now sort of ramped up in your nervous system. So, those are my thoughts initially. Do you want to keep going, or do you want us to intervene? Do you have any more to tell us, or do you want to?
I have more. He wears glasses. He has for the last 20 years. He's nearsighted. Let's see, what else? I talked to him about meditation. He said he has tried meditation. It does help with stress. I'm getting more into treatment, but I think I should go more into the assessment part. Yes. After the first visit, his neurologist also wanted to order brain MRI. And he was hesitant to do that just because, it's very nerve-wracking. But he did end up having that done, and it was unremarkable, thankfully. Let me just see. Okay, so the initial eval, then I went over the range of motion. His flexion was decreased about 15%. So he didn't have full neck flexion. His rotation to the right was decreased about 25%. Rotation to the left decreased 30. I do percentages, 35%. It's hard for him to turn, and he would have that increased pain on the left. And he said, when he's driving, he notices it too functionally. His side bending was pretty normal on my first visit. When he would rotate, that was an interesting thing. When he would rotate, his head would like veer down. He would look down and veer down. And so the first visit, I was trying to even get him to improve his motor control with that motion, to really improve how he was rotating, even if he was having pain at that end range, but not looking down and to the left. Does that make sense? Have you ever seen that?
Yes. Makes sense.
Yeah.
Okay, so the second visit, though, when I saw him, I noticed, and I sent you a video on this, that when he would side bend to the left, it just felt awkward And, this is the advantage of reassessing and having time with patients. I really didn't pick this up on the first visit of the eval, but when he would side bend to the left, he wasn't really moving throughout his cervical spine. It was almost like he was hinging. And that's on that video. When he would side bend to the right, it was a lot more uniform, and he would feel a stretch on the left side of his neck, like in the left upper trap. Okay.
Megan, does he have any other injuries? What's his medical history? Anything significant?
Yeah, no, his medical history was pretty unremarkable, except for, I think, he's a tennis player 10 years ago, had a labral tear on the right shoulder. So nothing else nothing else too exciting. Slight scoliosis, and some of those pictures that I showed you, I looked at him lying supine, and you could see, the rib cage on the left side is a little bit more anterior when you supine. So I'm thinking like the thoracic spine is a little bit more rotated to the right. And so maybe that was why rotating to the left cervical was hard as well.
Did you notice anything like facial wise on him?
Oh, good point. Good point. I did. So I knew what I was going into the initial eval to do. Like, I knew what the case was. And so because I had spoken to him on the phone before scheduling. And so I did a whole cranial nerve screen. Everything was fine, but it was just a screen.
Well, yeah, you rule out the bad stuff, right?
Yeah. Yeah.
Okay. Susan, do you have any other questions?
Is he right-handed?
He's right-handed, yes.
Yeah, okay. Yeah, I'm looking at the pictures. I know everybody can't see the pictures, but
yes.
I definitely see this shift in the thorax, but I also
in the shoulders too.
Yes.
Yeah, the shoulder as well. I'm wondering if
shoulders go to the left, right?
Yes. Yeah, the shoulder's higher on the left.
Yeah.
And but I'm also wondering if that might be just a little over recruitment of the cervical, the larger cervical muscles, just because of the pain and the guarding that he had. You have persistent pain, we're going to have some muscles that are going to switch on and just kind of overwork a bit.
Yes, and to palpation, the left side, those cervical muscles are definitely over recruited. I could feel that.
Yeah.
Yeah, for sure. Like splenius capitis for sure. Yeah. Upper trap for sure.
Mm-hmm. So Megan, his neuralgia, his symptoms into the scalp, are they constant?
Yeah, it's constant. And so the last time, so I've only seen him 3 times. And so the last time was when I had asked if there was any topical, I hadn't asked that initially, if they ever tried any lidoderm or anything there. And then I actually had said, he said if he touches it, it hurts. And I think like for desensitization, I think it's important to give some feedback and try to change the sensation, pain and how you perceive pain and sensations. It's all relative, right? So if you've had constant input to the system, right, it's good to actually change it.
Yeah.
I mean,
100%. Yeah. So I think that to me, there's like several pieces here. There's a neuroimmune piece for sure. There's probably a cervical piece. There's an underlying lifestyle kind of thing. And, it just all happened at once. It's kind of the way these things work. It's something, he got shingles, and that's when everything kind of probably just fell apart all over the place. So it's not going to be one thing that's going to do it for him, but it's going to be several, like, staying with foods that don't irritate and aggravate. I love the desensitization part because that needs to happen. It would, if just where is the borders, where does it feel, all of that kind of stuff, working with him. One of the other things that I kind of picked up on, he wears glasses and he works in the financial industry. He's got 2 screens or 3 screens going at once.
Good. Yeah, good point.
And he's 40, 47,
48. Yeah.
He's probably wearing progressive lenses, and he's looking down in the bottom of his glasses to see things. he needs to, if he hasn't done so already, I would highly recommend him going back to his eye doctor and getting refracted from his nose to the distance to the screen, so that he can have computer glasses that he can see, and take his regular glasses off, so that he has glasses dedicated to those screens, because I've seen this a lot. And if he's got that little hingy thing that he's doing from the video, in his neck, I'm wondering, especially since he's right-handed, people tend to kind of rotate to the right with the mouse. And then he's having to like side bend left to look over to see. It's just, it can be very subtle, but it can make a huge amount of difference for him to get glasses that will refract to the screen, refracted to, the distance for the screen for him. And he leaves them there. They're part of his, like, they live with the computer. You shut your computer down, you put your glasses on it, so that they're always there when you need them. But that can be of great help.
Yeah, and I did recommend after the eval, I spoke to him a lot about cardio program and I know you know tons more about this, Susan, than I do, but a heart rate variability and nerve irritation. So he said he likes to run, but his knees were bothering him. And I said, well, what about a Peloton? He said, oh, I haven't Peloton. And so I said, you got to start this tomorrow. You got to sweat. You got to move, endorphins, anything to change things around. And so, so he started on that. And he was, after I saw him the second visit, I did, PIVMs, mobilizations all along, the spinous process and the transverse process on the left, like C3, C4, all super tender and sensitive. And, he just feels great that, he's doing something about this, like that even if a mobilization increases the pain, he's like, I'm actually doing something, whether it is just the mechanical rotation that we're improving, but that he's getting some more input into an area that's been bothering him for a long time.
Right. And help him get away from that segmental regional stiffness. The other thing that came up for me when I was watching the video, and then I didn't see him do flexion. So you said that he was limited in flexion. The low-hanging fruit there for me is the CT junction. If you can get that going and see what input that has, that could help quite a bit, especially with him functionally turning in the car and things like that.
Yeah, so I'm just curious what you mean by, like, I have him doing thoracic moves on the foam roller, but what do you mean by input there?
So there's a couple of things you can do. You can mobilize him by, doing the hands interlocked behind the cervical spine.
Right.
And, come in underneath and do the lift mobilization. Or you can, but a home program that works. The home program that I found that works really well there is roll up a towel and put it underneath the CT region. So it's like really underneath thoracic vertebrae 1 and 2. So C7 slips back down towards, but he lays on that and then he bends his knees and puts his feet on the bed. And then what he does is he so the listeners can kind of follow here. He takes his knees and he moves them over his feet. So in other words, his feet stay planted on the bed and he pulls his knees forward over his feet. So that lifts his whole body and mobile. So it's like doing the mobilization from underneath instead of from on top.
But is the towel lengthwise or horizontal?
No, it's horizontal. Horizontal.
Okay.
Horizontal, right under the upper thoracic spine. And he can mobilize himself that way. It's just doing a mobilization from underneath. So if you can just picture that, his feet stay planted and he pulls his body over his feet, his knees. I just put my hands on top of their knees and say, move your knees forward over your feet. Move them towards the wall, wherever your feet are pointed, move your knees in that direction. And he can actually mobilize himself, which is nice because he can get the input kind of on a daily basis and not just wait to see you do that. So that could be extremely helpful there as well, I think, with just because that kind of is the intermediary region between thorax and cervical. So if you can free that up, get him to do that on a regular basis, that can help the input to the whole system going up.
Okay.
And and well, the listeners can't see this, but in the photo that you sent us, we always talk about center of mass and, having the person stand. And so one of the photos you sent us, these in a normal base of support, and you drew some lines for us. I just went on my iPhone and just edited it, and just, when you go on your phone, you can move and go edit. You can it'll come up with a grid, and you can just move the grid. And so when you put the grid, or one of the grid lines, right through the center of his feet into his pelvis, he's significantly translated to the left in his upper thorax and his head. Okay. And so that's probably offloading of something from years ago. But that, you could use that as like a barometer, but you definitely want to get him, his head and his thorax from a musculoskeletal standpoint. This is not the only piece here, as Susan mentioned. It's definitely multifactorial, but you want to see if you can get that cervical spine over the thoracic spine. You want to see if you can get that more centered. And doing CT junction stuff, like we just talked about, you could, you can have him do, self snags. You can do your traditional, your joint mobilizations. You can also just have him do, especially when he has multiple screens, you're going to have to make him aware of a bias to the left side, because I guarantee you he's a bias to that side. And another thought that I also, you may want to just look at, because you did the cranial nerve screen, but sometimes what I have people do is two things. I'll look at their eye sockets and see if one is deeper than the other. Because he plays ice hockey, he's probably had some head hits over the years that could have caused some issues, and he's young and he adapted. But I don't know if you have, but you may just want to see with his eyes on, with his glasses on, and or with glasses off, just to see if one eye socket is deeper, and that would indicate some issues with sphenoid. People who do craniosacral work, you just note it down. You don't have to just note it down.
Right.
And then what I also do is I just have people read like a piece of paper, something they've never read before, and I'll just have them read it and note if there's any disturbance or change, and then you'll treat whatever you find the driver is. I have them read it again to see if their vision is better or worse. And so because he wears glasses, and it definitely could be an issue. But I also thought, I don't know what you guys think about this, why not try some graded motor imagery with something like this?
Right. I was wondering if that was an option with the cervical spine. I've never done that.
I did it because I had chronic neck issues over the years, and I've done it. Actually, years ago, I actually spoke with David Butler about this. And he's
wow.
Erica, just take a look. This is before like the Recognize and all the mirror and the left-right discrimination came out. It's like, just open a magazine and look at people's necks and look at their heads, and
basically, the work is to notice. So when he walks down the streets of New York City, look for everybody's right ear.
Right, exactly.
So that you're doing right-left discrimination, because that's what the recognizes, and that's the first part of GMI is right-left discrimination, and help him bust that up and get some homuncular refreshment going. That's what the mobilization is doing. And you working on the motor control on the spine, with his left rotation, is by doing those novel movements and those things in there, you're helping, that homuncular refreshment, which is what he, really, really, really needs from that standpoint. And then, or when he is sitting in wherever he is, look for everybody's left hand, look for everybody's right ear, look for everybody's left eyebrow. He can do the app, the Recognize app for the cervical spine.
Yeah.
Right. Well, I feel like a lot, it's becoming a more acceptable treatment. But I see that a lot of times with, more with low back pain. I was recently reading Liam Manick's book Back Up, which came out, and they're talking about, pain and pain perception and greater motor and imaging. And I think it is interesting, but I haven't tried it yet with a cervical case. And additionally, I'm going to try it. What you were mentioning before about, where his center of mass is and what it's shifted at, it reminded me yesterday, I evaluated a patient who had lumbar radiculopathy, and I asked him to walk because I wanted to make sure he didn't have a foot drop. So I had him walk, and then I had him, I just wanted him to walk on his heels, and I'm watching him walk, and his head is completely tilted to the right, like significantly, like a good 20%. And I was like, your head's you're tilted to the, to the right. And he's like, oh yeah, that's how I have been for, like my whole life. And it's kind of like, these people present to us and, no one's symmetrical, but like, when is it contributing to their issue? And, when is it, what we actually should be correcting versus is that just, how they hold themselves?
Mm-hmm.
Yeah.
Or they adapt until they can't.
Exactly. They adapt so they can. If someone's, if someone coming in with right knee pain and they're loading that right leg more than their left, that's possibly relevant. It just depends on the whole clinical picture,
Right.
and and it sounds like with this guy here, I would give GMI a try. I absolutely would. And,
yeah.
I also think, and he doesn't have any visual disturbances or anything like that, but Susan and I have often talked about, working on patients' visual ocular reflex, their smooth pursuit, their turning.
Just fixing to say that. So one of the things we like, Megan, I don't know if you've ever heard me talk about the Clock Yourself app.
Yeah.
It's a balance app designed for people standing on the floor, to like touch the numbers of a clock. And the way that they set it up is it's reactive and not anticipatory, which is what improves balance. But for him, and he can do that. I mean, I think everybody should do that because it's all good for all of us. But for him, I just tell, people like him, and he's an advanced, he's good enough to stand and do this. For people who can't stand, I have him sit in a chair, but he could stand and do this. I just have them picture the clock on the wall in front of them, and their nose is right in the middle of the clock. So their nose stays still. The nose stays planted there. And as the app calls out the numbers, they move their eyes to the number without moving their head. So he may have to like his head still in the beginning so that he can just move his eyes. But that's going to give input back into that system from a backwards direction. And if there is a bit of trigeminal stuff going on, which there very well could be, it's going to really help that.
I was thinking that with the trigeminal.
And then if he holds his eyes still and they call out the numbers of the clock, he moves his nose to those numbers, but the eyes stay still looking ahead. So he can do head on eyes, eyes on head. And
got it. Yeah, because that first visit when he was veering and his eyes were moving, and I know that affects the upper cervical, musculature.
Absolutely.
How your eyes are visiting. So I really was, grateful that had seemed to improve, but I'll reassess that next time, and then I will suggest this. I think that's a great recommendation.
And the exercise he can do at his desk is to just, if his chair swivels, just sit there and keep his head in one direction and swivel the chair to, so that he can get left-right rotation in his neck. But it's coming from underneath rather than on top. So it's definitely, a novel input to the system that can help with homuncular refreshment. Because I think these financial people get in the groove and they don't ever move because they're just like following the numbers and the list and following the numbers and the stuff and scrolling and doing, and it's like, whoa, stop, but that could get some rotation in from a novel perspective for him too.
Yeah, I remember when I was on Wall Street, I had a horrible neck issue, and I would this is like there was no wireless back when I was trading, but I would have like a headset with a long wire because I had to physically get up from my desk because of the screen issues. I was just going to say one more thing. Oh, in the office, like when you have them on the plinth, you can just literally, you can just put something on your wall, like a vision chart or whatever. But literally just have him maintain his thorax pretty sort of straight or stable, and just have him turn the head, okay? And then what you can also do is just have then hold on to his head, like just put your thumbs under the occiput, and then have him fixate on something on the wall, and then just turn the trunk, similar to what we were just discussing about doing himself. But you can also do that in the office. And because you could see if there's any issues after, whereas when he does it at home, you won't really see it. So you can just try that as well and just have them focus on something on the wall. I think,
Right.
that will also help. But I do think like the nutritional, the musculoskeletal stuff, and also the GMI and other things we suggested, I think you have at least a good way to start, and then you can see how he responds to all of that.
I did try some contract relax with the splenius capitis into the rotation and up a little bit, and including his vision and then his head.
Perfect.
And that definitely helped after the first, that first visit.
Yeah.
But he was sitting. He was in sitting when he was doing that, which is a more functional position.
Yeah.
But I probably should have maybe tried it in supine and then sitting. But I was just like, okay, let's try to fix this.
But he's I don't think there's anything actually wrong with that. You're seeing what you see when you see it, and it may not be an issue for him laying down. But the input, what you saw in the seated position, that's where I would have gone first. Just like, it's kind of like, it hurts when I bend over and pick this up. Okay, stop. Let's figure out a better way to bend over and pick it up. Like, so I think that's, actually kind of really functional myself. I really like the fact that you did that. And I like the fact that you got instant feedback from it. That would be interesting to see how his left rotation and his motor control works as you work on the ocular the ocular cervical reflex kind of pieces. One other thing to add in is that if he wants to try something kind of cool, he can research and look up a lion's mane tea. It's a mushroom.
Mm-hmm.
The lion's mane mushroom. They make tea out of you just go to Google and look for a tea with lion's mane in it. That's been shown to really help the kind of neural irritation stuff like this. It's not going to hurt anything at all. It's totally healthy. Just tell him to, maybe have 1 cup of coffee and then have a cup of lion's mane tea and see, just see if that helps her. It'll be something over time that could be also helpful that he could do. Because it sounds like.
So now the last visit, I'm sorry.
It's okay. All I was saying is he's looking for things to be active with, like I'm doing something to like change this.
Yeah, to empower, right? So the last visit, he stopped the gabapentin and he said there was no change. And I'm just interested what you guys think about that being prescribed. And I do think there's a time and place for this. I don't know really what your opinion is.
I don't have a straightforward. I've had patients on it for chronic, radiculopathies and things like that. But, gabapentin is used so often a lot for off-label issues as well. He was on 600 milligrams, you said, twice a day when he, right? And how long was he on that for?
Let me see on my notes. I guess that was, I'm not really sure because he then said for 3 or 4 months, he was then down to 200 milligrams. So I don't really have a good.
So question then, that's okay. So I don't have a problem. In fact, he's off the gabapentin now and he's no worse, or I don't think the gabapentin probably helped him. My question is, he was on Valtrex for the shingles. How long was he on that for? You said 2 weeks?
2 weeks.
That doesn't seem like a lot. I don't know. That seems kind of short, but
do they only prescribe that while you have the outbreak, or what? I don't really know. How long they usually prescribe that.
I've had a family member who had it, and she was on. This is a while ago, but Famvir, which is the antiviral at the time, for like a month. But I don't know what the current protocol is. Is for shingles, but
it depends upon. Some people still use the Zostrak cream, that's made out of the pepper, and other people use Valtrex. A lot of people weather the storm.
Yeah,
if that's
a virus.
Bad. Shingles has such different presentations in a lot of different ways. It sounds like he got the right care for sure. It's just
early on.
Yeah. Well, they also followed up to make sure he didn't have any ocular other things, because you're talking like a C1, C2 dermatome at the top of the head there, and
Right.
So that's those. The issue with these viral things is that he may be there. There may still be a viral load, even though he doesn't have a physical presentation of the blisters and stuff. But sometimes with people, the shingles virus lasts a long time in the system.
Yeah, I mean, it has been over a year, but it still could be in the system. And and additionally, they did rule out, that Ramsay-Hunt syndrome that, Justin Bieber had, brought some attention to it. I mean, these are viral things that happen to young people. It's not just, older people, although I did have a case once, a low back pain case, and it was a man in his 80s, and it was really, I couldn't figure it out. And I actually thought it was cancer because it was pain at night and a history of cancer. And sure enough, a few days later, I sent him back to his GP. It was shingles, So the pain that exists with shingles prior to the outbreak, it's important for PTs to know about, because it usually it'll present itself. Not that you can usually diagnose it before the outbreak, but it's important to know when pain doesn't follow a typical pattern to notify the GP.
Yeah, and I think
make sure you get some follow-up care, especially like, I don't know, this could be a number of things, but it's not fitting a mechanical pattern. Absolutely.
Right.
Yeah.
And I was just going to say, the name of the game at this point is desensitization. I mean, you can make a case for any of these suggestions that we made, as long as that, helps them get desensitized, because, any kind of virus will leave your system, as we know, vulnerable still. So, even if you want to mobilize C1, C2 at the, with the desensitization as the end game, that's fine. If you want to, change the diet, it's all, the goal is the same, and there's many avenues that you probably need to go down. I don't think just mobilizing C1, C2 is going to get this guy better. I think you have to sort of run each course down. But shingles, it is extremely painful, and it can take a while for it to go. The long-term effects from what I've seen, but you want to make him comfortable, and you want to at least have him, feel like he's making progress, right? And
right.
No,
and they're not recommending the vaccine until like over 60, correct? Right now, our medical system.
Yeah,
I'm
not sure.
You're probably right.
Like
right?
he's young. He's young for the vaccine. You know what I mean?
Has he had
so painful.
Has he had chickenpox when he was younger? He must have, right?
Yes.
Yeah.
Yes.
Okay. I think it's 60 over. I don't know.
Yeah, he was asking about, whether or not to get the vaccine, and I said that, that's obviously a decision for the GP, and I'm sure there are stats on that stuff, whether or not you get the vaccine after having, and the vaccine is now it's 2 shots. So, I knew someone who had vaccines and had an outbreak in between both the 2 vaccines. So that was just unlucky, but and painful. But and then I don't really have an opinion on acupuncture or I don't know, dry needling. I don't do dry needling, but do you guys have any opinion on that stuff?
Again, I along the lines of just thinking about him, I think if you chase down those things, those are going to be quite helpful. If I was recommending acupuncture, I would want somebody who really could look at it, who could follow acupuncture, like for the for the neuroimmune response. For that, almost Ayurvedic type of or Chinese medicine type things, just because, again, the end game is like, and whatever we call it, this started with the shingles. There could have been a whole lifetime of setup to happen before the shingles, but the shingles was the outbreak, was the thing, and everything else has been cascading since then. So all of that goes to, will the varietal of things that he's doing A, not be harmful, and B, be helpful. And it sounds like just empowering him to like make changes and do things, and that it doesn't just have to be this way, has been really, really helpful for him. As we know, it requires, knowledge and movement and the neuroimmune response, all being addressed. Everything touches everything. So it's just like which thread to pull, and you're the physical therapist. So definitely the mechanical and motor control, reflex, optimization is in your wheelhouse. And then, recommending that, maybe he should talk to somebody who's really good with, like an autoimmune type diet, just because he may have a little bit of autoimmunity that has shown up now since he had the shingles virus. Who knows? And like some acupuncture could be helpful. As long as the exercise isn't making him have an increased neuroimmune response 6 hours or the day later or 2 days later, then the Peloton's great.
Right.
So those are all good things for him to do, and they're healthy things for him to do. So those are all going to be extremely positive. And that's just going to, again, we change the way we think about things. We empower people, and they have more access to serotonin and oxytocin and endorphins by doing things that empower them, that they're empowered by.
Yeah.
So it's got to be good. Don't care.
Right. I mean, and I was a little nervous about, the Peloton, because I don't want this, horrible cervical positioning, because I did give him deep neck flexor exercise and, not just to be in that upper cervical extension. Right. And I am releasing the suboccipitals, trying to get that flexion. And so I said, go on the Peloton, but like stand up and sit down, get your heart rate up, and don't just sit in this like one extended upper cervical spine extension position for hours with your forearms resting. I think that's important.
Yeah, because he's sitting all day, and it kills me that people, and we all do it. We sit all day. People will sit all day, and what do you do for exercise? Oh, I get on a bike. Like, you're sitting. You're still sitting.
I know. But you can stand on the bike too. You can stand and you can sit and you can stand and that changing of position is important. It's good.
Yeah.
You get your heart rate up. Especially if the running was not. I mean, ideally I would even suggest running, but if it really aggravates his knees, that's a whole other issue.
Yeah. Well, do you have any more questions for us?
No, I mean, I think this is really, really helpful. I love talking to you guys. You're so smart, and your input is really valued. I really appreciate your time.
Oh, you're welcome. You're welcome. We loved having you.
And we're opening
this is a treat for me.
To any of our listeners out there who would like to join us. Again, toughtotreatpt at gmail.com, right?
Yeah, toughtotreatpt@gmail.com.
Yes. So drop us a line. Let us know what you would like to talk about.
Yeah, because it's nice that we go back and forth on our patients, but I do think the beauty is bringing other people on too, because neither Susan nor I have any knowledge of who these people are, and so it's nice that that we can help others. And so, Megan, thank you so much for coming.
Thank you for coming.
Oh, thank you.
Him and brainstorming with us. We appreciate it so much.
Yeah, keep
fun.
Us posted. Keep us posted as to what happens. Yeah.
Okay. Thank you.
You're welcome. And once again, for the new listeners, just if you're not familiar with us and you would like to leave us a review on iTunes, that would be fantastic. It helps us move up in the algorithm, and if you've sort of found value with our content, it would be great for you to do that. And once again, for the new listeners, our actual website is toughtotreat.com, and we have a couple of clinical pearl PDFs and a great PDF that Susan wrote on chronic pain and sleep for you to download when you visit the site. So thank you again, and thank you, Megan. And Susan, I will see you on the next episode.
Absolutely. Thanks, everyone.